As our expert panel is getting situated, I wanted to share a couple of things that we've learned over the last few days. One is that when Dr. Baser retired, there is a huge hole in our community that these folks are working so hard to fill to get you in. And we already had long wait times, but it's really bad right now. And so we reached out to AMDAP, which is the Association of Movement Disorder Advanced Practice Providers, and said, we need to broaden the education of our nurse practitioners and physician assistants to understand more about Parkinson's disease. And yesterday, Jessica, is it Kappel or Kappel, and Kaci Monhart, Kaci from AHN, Jessica from UPMC, joined Dr. Van Laar, who many of you know, and trained, provided CME credits for other APPs to learn more about the disease. Also learned that AHN is getting 2 new movement disorder specialists, which is great. And I want to make sure that you meet Dr. Oblack, who is a movement disorder specialist in Greensburg, Latrobe area. And Dr. Suski is also up here from UPMC, who heads up their neurology clinic. So some of you posed questions to us when you registered. So we're going to talk about some of those questions, and some will be directed to certain people, some we may have differing opinions on, and we may ask everybody to weigh in. Well, let me put on my glasses here. Oh, and one other thing, if you haven't, many of you love Talk with the Doc with Dr. Leichliter, and it's been a great program, and it's an ability to ask any question you want once a month to him. We also just started a program with Dr. Priya Cardone at UPMC, PD Parlor. It's at lunchtime. Her first session was extremely well received, so check that out too. Dr. Cardone is doing more of a topical deep dive, so join us in those programs. So I'm going to start with the questions that were posed in registration, and once we get through many of these, then we will move on to questions in the audience, and we have folks with microphones. So think about a question you want to ask. First question, Dr. Oblack. How do you handle hallucinations when they occur at night where the patient is acting out their dreams? He is trying to get out of bed and trying to work. This is not dangerous, but I am concerned.
So for the most part, as long as hallucinations, overnight disorders.
Is it high enough?
We'll just kind of hold on to it. How about that? Is that better? So for the most part, as long as hallucinations and overnight issues aren't distressing, aren't causing problems, for the most part, it's really an open dialogue of how much does it affect you. If it's not causing a problem, usually I tend to not make any changes. Otherwise, if people tell me it's distressing, it's causing issues in the household, then you can talk about minor things, adjusting medications that they're already on to reduce the amount of dopamine that they get overnight, because that can be problematic. Also, things as simple as adding melatonin. I find a lot of relief with that, among other things, but I try to stick with very simple things and try to take a hands-off approach if it's not concerning.
Thank you. Kaci, with PD, can you get internal quivering?
Yes, you can. Yes, you can. It's often internal tremors. I always ask, Can you see them? Do they bother you? Are they responsive to the medications you're already on? Does it fluctuate with medications? And then just kind of weigh the pros and cons of making adjustments to the medicine. And if it is bothersome, then of course we can try, altering medicines. But if it's not, then we just kind of hold off on it, keep an eye on it, and see how they do.
Can I add something?
Sure.
Internal tremors sometimes are not all PD as well. So when you have issues, I like when people make lists of things and bring them in, because sometimes things that are happening, we like to rack everything up to Parkinson's, but not everything is Parkinson's. Your thyroid could be off. You could be on an antidepressant that can cause tremors too, so sometimes it's getting off of that medicine. So yeah, the question is, does the tremors get better when you take your medicines? And if they do, is it a wearing off phenomenon? But essential tremor can have these, and like I said, metabolic problems can have these. So sometimes it's not always Parkinson's, but it's good to ask us if it's bothersome for you, because we don't know, because we're not seeing them. So if we can't see them, we don't think they exist, so you have to let us know about those things.
Thank you. Jessica, I experience droopy eyelids as my medications are wearing off and experience a black line over what I see. What can I do about this?
So I'm not entirely sure what that may be, but I would talk to your neurologist about it and see probably a neuro-ophthalmologist as well. But I'm going to ask the panel if they have any other ideas.
We can always say pass too. Go ahead.
So actually this is more common than some people think. It can just be actually a wearing off phenomenon of your dopamine therapy. A lot of times that's probably the most common reason for this. Other times there actually has been issues with coincidence of other disorders like myasthenia gravis that can cause that issue. Blepharospasm, where the muscles that surround the eye actually want to close the eye shut. That would be amenable to something like Botox. There is also what's called a dystonia, which I know some of you probably have heard of, in which case actually there is an eye closing dystonia. A lot of times that will respond to something that's called a sensory trick. Touching a certain area that allows you to open your eyes a little bit more. Dystonia medications that are out there, but also sometimes will respond to dopamine therapy. And so, like Dr. Suski had mentioned, kind of keeping a list and a timetable of those kinds of symptoms, it really gives us clues on how to best approach that.
Once again, it can be something else, but if it responds to medicines, it could be a wearing off phenomenon. There's some pretty odd wearing off phenomena that we see, and not everybody's the same, so we have to kind of hear what you say about if the medicines are helping or not, but it could be something else, like I agree with him, myasthenia gravis.
I know the woman who asked this question, and I love her, and I was hoping somebody would say that she could get an eye lift. That didn't come up.
That would be my vote.
Dr. Leichliter, I'm giving you a tough one, but I think you were forewarned about it.
I didn't study for the test.
It's okay. I'm confident.
It's okay.
Part of our play today talked about not discussing the difficult subjects, and we see that a lot. And so we're trying to address that as an organization and maybe bring to the forefront things that are tough, things like sexual dysfunction. But you opt in, so you don't have to sit through it if you don't want to, but opt in and learn more about it. This one is even harder than that, but I think it's a fair question, and I think you've probably heard it before. Why does no one want to discuss exit strategies like euthanasia? Seems a choice that can be logical for some with a torturous, progressive, incurable, and terminal disease.
It's an easy answer to the question and a hard answer to the question. The easy answer is it's illegal in this state, for now. And so that's why we're never going to talk about it. None of us, I'm not going to say it, I'm never going to bring it up because it's not something we can offer. It's not something that's available. It's not something that we, but I did get that question ahead of time. And I thought about it. And I'm not sure how I feel about it. And I don't think I'll figure out exactly what my thoughts will be until it is something that maybe is available or legal or reasonable. And then I'm going to have to figure out how to come to grips with it. Because it is tough. Believe me, I see people start of disease to end of disease. And again, I think the play, if you guys were here for it, really not only hammered home a lot of the things I don't necessarily do great in my office, which were evident, but also some of the struggles that you deal with at home, in your own head, interpersonally between you and your significant other and your family. And these are tough questions. Again, the easy answer right now is it's illegal and we can't talk about it. There's nothing I can do to offer or help or do anything like that. But down the road, this is probably going to be something we have to think about. And then it is going to be a discussion. And much like if you've ever listened to anything else that I've ever talked at, I always say make a list, bring your questions, and have a discussion. If you're thinking about it, if it's weighing on your mind, if it's something that you really want to know or think about or consider, then we need to have a talk about it. It's not just life and death things, but DBS, medications, exercise, sexual dysfunction, mood, all of the things that come along with Parkinson's disease. These are things we have to have a talk about. It's not like something you just come in and I say, yep, that's a great idea, here you go. That would be bad. And so again, I think more of this will come as we see this country change over time. Again, today I don't have to actually answer that question, thankfully, but at some point I might, and then it's really going to be one-on-one personalized conversations that we have about what are the options, why are we talking about what we're talking about, what kind of things play a role or go into making that decision or make one person choose that versus another. And then I think we have to sit down and personalize what we do, and that's the way we'll approach it. We'll talk to you one-on-one, we'll figure out what makes sense, and we'll go from there.
I can say something too. So this is a very difficult topic. One, because going into medicine, we take the Hippocratic Oath, and that means do no harm. So there is that. As physicians, we want not to do harm to somebody. The other thing is politics. I'm not going to talk about my beliefs, but there are certain religious beliefs that might be the lawmakers in the back of their head, just like the abortion rights that we're talking about now. I mean, there are certain things that are kind of underlying how things and laws are passed as well. Dr. Kevorkian, I guess everybody remembers him. He had, 7 to 8 years sentence just for helping out people. So there's a lot of things that's on the back of our minds whenever we do talk about it. There are some countries, I guess the Netherlands, they've been in the news recently. And I was just telling Jessica on the way, because this is the only question I looked at beforehand, but I saw something in the news in the past week that somebody that was 29 years old in the Netherlands wanted to end her life because she had bipolar disease. So then the questions are, like, who would this pertain to? What part of the stage of their disease would this pertain to? If somebody has a mental disorder or mental disease, are they candidates for this as well? There's a lot of things that we need to think about, and it's not an easy topic at all. I think we all agree with that.
Absolutely.
I'm trying not to block you folks over here and create feedback with the mic. So, Dr. Oblack, can you share suggestions for freezing?
So this is one that, I think really our colleagues with physical therapy really do a great job. I would say probably in my own experience, the most beneficial thing to patients has been what's called cueing. Things as simple as counting as you're walking, counting steps, almost these distraction maneuvers that work to keep the body moving and not seizing up on you. Outside of that, this can be another example of a wearing off phenomenon. And so again, it's just another thing where you need to stay on top of when you're taking medications, when you notice a symptom starting, and seeing if you yourself can recognize patterns. That's great. But even if you can't, bring that information to your office visit, because we might be able to make sense of it for that. But I do think the physical therapy folks have, just excellent techniques and strategies for coping with all different things, and freezing being a really great example of that.
I usually tell my patients that there are two different brains. The majority of the brains, you can override it. You can march in place and sway back and forth, things that you learn in physical therapy. And then there's the minority of the brains that if you try to do these things and override it, your brain backfires. And those are the people that I say, if you try to override it and it just makes it worse, then take a deep breath, count to 10, and try to do it again. But sometimes it's by doing these maneuvers and I know there's a couple people in here that have some really interesting ways of, they learned on their own to override it. John had the ball that would kick, but he said in Pittsburgh, where's John at? John. Oh, he stepped out maybe. He said in Pittsburgh there's hills, so it was either kicking it up the hill and it was rolling back, or kicking it down and then it went away, and people kept trying to give it back to him. So I have somebody who has a string with a metal ruler that she throws it onto the ground, she steps over it, and then she wraps it back up and it gets her moving. Sometimes these are things that you learn. There's some areas in your house that you're not going to be able to get into. Laundry rooms with laundry baskets, or a Pittsburgh bathroom that's really tiny. So areas that confine the brain are harder. So you might have to think about where in your house it is a problem, get some physical therapy ideas, try to time it out. Is it something that we can help you with the medications? And then figure out if you're the minority of the brain. I think these are the type A personality, that's me, that when we try to override it, it just backfires. And our waiting rooms are never conducive for, oh yeah, John did step out because he is like, so I think these are things that you'll find out over time too, as long as you document them for us.
We've even had some people who know certain areas of their home get them into trouble with the sticky feet, so they'll put colorful tape on the floor to step over. And like Dr. Suski was saying, people come up with some really creative ideas. They may listen to music or hum a tune, and that might help them to break through those freezing episodes.
Dr. Leichliter, another one for you. How do they know that exercise delays the progression of the disease? How do they know
I knew
it
you were
works?
going to ask me that question.
I've heard you answer it before, so I figured I was
I
throwing you a
love to talk
softball.
about it. Well, I mean, the short answer is we don't. Even though I say it like we do, we haven't quite proven that it is disease modifying, but it's my favorite topic. Exercise is the best medicine for everybody, for everything. Infinitely true for people.
Are you having trouble hearing?
Infinitely true for people with Parkinson's disease, but exercise is the best medicine for everybody, for everything. There we go. So we're working on that. I know you guys are in the SPARKS trial, and we're trying to prove that exercise really is disease modifying and it slows down disease progression. But I'll just tell you in my experience, and I've said this time and time again, and I will take it to my grave even if the SPARKS 3 trial doesn't pan out for us, the patients that come to me who exercise the most do the best. 10 times out of 10, 100 times out of 100. The people who come to me, and no matter how many times I harp on them about exercise, which I do, every office visit, everybody here knows this, and either I can't get them motivated to exercise, or believe me, there's countless reasons why people don't exercise. I won't even say don't want to exercise, but don't exercise. It's not easy. Mood plays a role, physical ailments play a role. There's always things that can come in between you and getting up and moving, as we heard again in the play. And the people that come to me where I struggle to get them motivated or I struggle to get them up and moving, they tend to not do as well. And this is just what I've seen over the past, I don't know how many thousand people I've seen, 10 years that I've been doing this. It just keeps playing out. And 10 times out of 10, the only guarantee that I ever give to any of my patients is if you exercise, you will feel better. And I know this because 100% of the time, people come back and say, when I exercise, I feel better. So it's a lot of things. There's studies out there to support the use of exercise in Parkinson's disease. Have we proven it, that it's disease modifying, slows down disease progression? No. I'm hopeful we're close to that with these guys because they're doing the study. But even if that comes back as negative, because exercise really is a hard thing to study scientifically, I have no doubt in my mind that exercise really does keep you doing better longer. It really is the best thing for you. As much getting up and moving as you can do is key to success, and I'm going to take that to the grave.
Thank you.
And the studies have shown that 20 to 30 minutes of cardiovascular exercise is what can slow the progression of Parkinson's. So we do sound like broken records, but we'll tell you every visit you have to be exercising.
And you're going to ask what the best exercise, everybody asks us these questions, what should I be doing? And I always say it's what you enjoy the most that you're going to be compliant with. Because if I tell you you have to do X or Y or Z and you hate it, you're not going to be compliant and therefore you're not going to do it. So it's very important for the compliance. It releases, we know that we release these endorphins whenever we exercise, so our mood is better. They've done cognitive testing on people before and after exercise and see that their scores have improved. So it can help with mood, movement, and memory.
And this is one of my favorite topics, so I'm going to keep talking. But we're just so lucky in this region that we have the Western Pennsylvania Parkinson's Foundation, because if there is an exercise you can think of, they probably have a group doing it, from dancing to yoga, boxing. So there are just so many things you can get involved in.
Thanks for that shout out.
Oh, one more thing. Make sure you're safe doing it. Because people tell me, oh, I'm going to go swimming because if I fall on land, it's going to hurt, and if I fall in water, and then that person couldn't swim. So, I mean, there's also common sense that has to be a little bit in, and do what is, if balance is a problem, putting your leg up and over a bike to get onto it might be a problem. So, be safe. That's also our other thing that we want to emphasize.
The other rule is you're not allowed to fall. So there's a few rules, and those are them.
Kaci, the two questions are a little bit alike. One is, does a gluten-free diet help with symptoms of Parkinson's disease? And the other is, would love to hear more about the role of nutrition in managing PD.
So I'm not sure if anything officially came out about nutrition. There's been a lot of studies on it, and they really kind of come down to what really is the Mediterranean diet or some variants of that. But we know gluten does have some inflammatory aspects of it, and could a gluten-free diet maybe minimize that, help potentially, but I don't think we have any hard, fast facts on that. And I think if between diet and exercise is gonna win. But anything in moderation is really just kind of the best thing, and it's really hard to follow the Mediterranean diet where we are here. So just things in moderation and just doing the best you can.
Thank you, Kaci. Dr. Oblack, is Parkinson's a prion disease?
Okay. So, actually, Dr. Leichliter and I were actually talking about this earlier today. This is a question that has come up actually a long time ago. A true prion disease is when a protein in your system is abnormally folded, and the presence of that creates normal proteins to abnormally fold. And so it's this exponential cycle. You will still currently see debate about this in terms of, is this a prion disease? Is this prion-like disease? I'm more of a purist on this topic. I think of a prion disease as truly normal protein gets abnormally folded and then causes other normal proteins to abnormally fold. If you follow that strict definition, I don't see Parkinson's disease as that. I don't know if my colleagues feel differently, but it is still an area of debate.
We just stick with I don't know. And Dr. Suski, I don't know if you were there at the movement conference like 10 years ago when I was just a fellow. there were a couple papers that came out about this, and there was a big talk about how you see this spread in cell model of Parkinson's disease, but then it went away, and everybody stopped talking about it. And so I don't know if it's just because there was nothing more to say, we couldn't do anything about it, or at the end of the day, if they decided that's not true. But regardless of how it spreads and how it goes, which model you believe in, we're not sure enough to know for fact.
And if anybody has an idea and want to tell us, then we can win the Nobel Prize. We will split it with you guys.
Here's a softball and a tee for you, Dr. Tim. Can you share suggestions for delaying the progression after first being diagnosed or having prodromal symptoms? Say it.
Exercise.
We know it's coming.
I don't know the answer. I can't think. No, I'm just kidding. It's exercise. It's always exercise. It's always the right answer. It's always going to be my favorite answer. It's always going to be what I talk about the most. And not because that's what I want it to be. Believe me, if there is a pill that comes out that does that, or if there's a specific thing that comes out that does it, we're going to be talking a lot more about it. We don't keep secrets up here, believe it or not. We're not saving the best thing to be surprised. It really is the only thing at this point that we think potentially slows things down or delays the onset of somebody who's going to develop it. And this is why it's so hard that we're working on genetics. We're working on trying to diagnose it earlier. We're working on novel tests to try to figure out the answer. And all of that is great. Believe me, I can't wait to have some of these things, but all of it is going to be even more useful when we have something better to tell you than just exercise. But the short answer is, and I just had this conversation with a patient the other day who was considering about getting their kids genetically testing. There was clearly a genetic component to their onset and their disease. And I said, well, you can talk to your son about getting tested, but at the end of the day, my answer to him is going to be, now's the time to be healthy. Get to the gym, exercise, get up, get moving, pay attention to diet, although I don't know as much about it as I do, think about exercise. But these are the only things I have to offer you anyway. And so again, that also comes back to whether or not we should be genetically testing people. That's a different conversation, but the short answer really is exercise.
I knew that was coming. Thank you.
It's a long answer for a short answer.
I have a couple of research questions that I'm going to pose to Dr. Suski, given
You're going to say that.
UPMC's role there. Is there any research and/or help for PD patients and their caregivers in recognizing early symptoms of Lewy body dementia and coping with them?
We do have a study looking at PET scans and looking at brain scans right now for Lewy body. Are the families, and was that part of it too? Can that be for the families too? I believe these are just for patients that are symptomatic. They're looking at even mild cognitive impairment with some of these scans. We just got awarded the Lewy body Research Consortium Center of Excellence, so we might have a couple more studies down the road. We will. And we partner with the Alzheimer's Disease Research Center too. So Dr. Berman, Sarah Berman, is the director of that center, and she also goes down to the ADRC. So right now, we're looking at imaging. That's what we have right now, but it's only for patients that are symptomatic. Did I answer the question?
I think you did.
Okay, because I kind of, once you said, I get the research question, I went, and then I didn't hear much.
And the Lewy body part's tough, actually, and I don't know if you guys looked ahead to the Movement Disorder Conference coming up in September, but one of the talks is the controversies is Lewy body disease and Parkinson's disease, dementia, and hallucinations a spectrum of one thing, or are they separate? So even in our world where we talk about research in these things, it's not known. We're still trying to figure this out.
Okay, here's another research one for you, Dr. Suski.
I just did
Can
one.
you talk about new trials with stem cells?
No, I can't.
Okay.
I think stem cell research, I always say the comment that I feel like we have 2 steps forward, 5 steps back with it. And then the government sometimes shut down these studies as well. So there are there's embryonic stem cells, there's mesenchymal stem cells, there's lots of different ones. The question is how reliable why is there all these, oh, okay, that's not me being like, pictures being taken, or you recording me and my opinion about this. Yeah, so, sometimes when you do studies, you want to have like limiting variables, and you want everything to be the same with each patient, so you know if what is happening is true or not. Sometimes when you're using different batches of embryonic cells and mesenchymal cells, I mean, sometimes it's like apples and oranges. So I don't know if anybody else has any other questions or comments about this.
Stem cells are tough. I mean,
it's
we've been looking at stem cells for longer than I've been doing this, and we still haven't necessarily gotten that close or figured it out. So we don't know the answer because there is no answer just yet. More to come.
Yeah, there was one recent study where I did my fellowship down in Dallas. A neighboring facility finished up a phase 1 trial down there that did show promise. It was with Dr. Scheiss, and they actually did just complete a phase 2 trial at the end of last year. Those results, I haven't come across the published results yet, but the phase 1 trial was promising. Obviously, these are very tough trials to hold, and so limited numbers of patients being treated means that there's always going to be this question of, is it a reliable result? Yes, there's going to be ongoing pushes for it, but the long and the short is it's still early in its development, and it's going to take more time.
So, do you guys understand what a phase 1, phase 2, phase 3 trial is? I can wrap it up in a nutshell.
Okay.
Phase 1 is limited number of sites and a limited number of patients. Most of the time, it's active drug. They don't usually have the placebo arm during that time. Phase 2 is more centers and more patients, and then phase 3 is the last stage before it goes to FDA approval. So there's many sites, and phase 2 and phase 3 can have a placebo arm. So the first one is this drug safe? That's phase 1. Phase 2, is it doing what we want it to do? And phase 3, is it better than what else we have? So when a drug goes into phase 1, it's less than, I think, around 10% or less that actually make it to the market. So, and this is many years. So sometimes people, get excited about certain phases, and they're like, when is going to be ready for us? And, it takes years. And, the FDA is a horrible thing and a good thing too. It makes sure that these medicines are safe for us. So there is a reason why it takes so long. And I have some really interesting studies that people want to jump into, and they may not be candidates and they want to do the compassionate use, but some of these studies, there's no benefit, so you're also risking safety too. So I get it, I'm frustrated with the FDA as well, but it is to our advantage and our benefit.
Okay, Jessica, how long does it take for hallucinations to go away after ending in tachypone?
So I don't know that there's an exact timeline for that.
3 days.
I wish I could say as simple as that, 3 days. Sometimes it could be as soon as you stop taking a certain medication that may be causing you hallucinations. You might want to give it 3 to 5 days. But also, I wouldn't, if you're taking a medication and you think it might be causing you a side effect, don't just stop it. Call your neurologist and get instructions to slowly taper off the medication. Sometimes just stopping a medication can cause some bad withdrawal symptoms. So yeah, I can't give an exact number, but a couple days after tapering the medication, whatever side effect it is might
Don't
calm
jump on
down.
3 days. I made that number.
Yeah, and you can
That
call
is
the
not written in
APPs
stone.
too, because they're really good as well to answer that question.
They're the
for
best people to answer that question, actually.
The one thing we need to know about hallucinations, because it could be us doing it to you. It could be our medicines doing it to you. It also could be urinary tract infections and other things as well. So kind of how I describe a hallucination is if I go into an empty room and there's a ball, that's a visual hallucination. If I go in and there's a ball and I see a cat, that's like a visual distortion. So sometimes you need to see an ophthalmologist or get your, like a good exam, because it might be not, it could be your eyes playing kind of a little bit of a trick. If I'm sleeping in an empty room and I wake up and there's somebody in the room with me, that's not really like a hallucination. That's that REM behavioral sleep disorder. And sometimes that's what we were talking earlier about, the vivid dreaming. So that's different. So people come in and they'll say, I'm hallucinating, and I'll ask them, well, what time is it? And you can also take naps during the day, right? And wake up and see people in the room. Or see kids or bugs. The nighttime also plays havoc with us, so if we can't see something, we might have a little bit of a distortion. And I always say, whenever daylight savings time comes around, a lot of our patients start to hallucinate because the sundowning happens at like 4:30, 5 o'clock. So you need to tell your physician though, and just because you're seeing something, it could be us doing it to you.
And just to add something else, if it's not medication induced and we rule out infections, it might mean that you need a medication to help calm down the hallucinations too.
I was going to piggyback on that and come back to making sure you get your eyes checked and your ears checked like we learned this morning. It's important.
Kaci, please address the symptoms of restless leg syndrome and the relation to Parkinson's disease.
Sure. So restless leg is kind of when you feel like your legs, it might be painful, you might perceive it as cramping, or just really just discomfort that's relieved when you get up and move. There is some correlation to having restless legs and Parkinson's. But again, a lot of the treatment strategies that we utilize for restless leg kind of overlap with some of the Parkinson's disease medication. But with this, it's important to, be evaluated appropriately, doing lab work, because there's a lot of decreased iron that can be correlated with that. So making sure that this is not something that's potentially treatable with either iron supplementation or infusions before we kind of go to some of our medicines, which have, the potential for side effects. So there is a correlation, and it is treated similarly with some of the same medications.
But again, the key is bringing it up. So again, much like has been reiterated multiple times over, and we always talk about, if you don't tell us, we don't know.
Okay, last question that I have here. And Tim, you were spared from the research questions, so forgive me for this one. Who is trying to lower the high cost of Parkinson's meds?
Not successfully. As I always tell my patients, don't ask questions you don't want to know the answer to. There are groups out there doing this. In fact, I just read something in either the Neurology or the Movement Disorder Journal about how they were just talking about this, how the price of drugs has gone up exponentially compared to typical inflation and everything else. And they said they're working on it, they're lobbying, but the medical field is not very good at lobbying politicians, not nearly as good as law firms and other groups. We'll just leave it at that.
Pesticide producing groups.
I'm just going to say other groups. So people are sort of trying to tackle this problem because it's a huge problem, right? You come to my office, I say, here, take this medicine. This is the medicine I think is the best drug for your specific problem. And then you come back and say, I couldn't get it. It was going to cost me $1,700 a month. It stinks. Again, that's taking my ability to treat you what I think is the best way to do it out of my control because of cost. We know this is a problem. Everybody in the room knows this is a problem. Probably everybody in the country and everybody in Washington, D.C. knows this is a problem, but there's also a lot of money involved, and money runs the world, as we all are also unfortunately well aware. And so theoretically, there are people from different groups. The American Academy of Neurology is tackling this problem. The Movement Disorder Society is tackling this problem. Probably the foundations are trying to tackle this problem, but it's a hard problem to tackle because there's so much money involved. And so I think those people are working on your behalf and our behalf to try to really help us solve this problem, but we're up against a giant, and we're always going to be up against a giant. I tell my patients 10 times a day, look, the insurance company dictate what I can do. They run the show. They tell me what I can and can't give you, where I can and can't send you, what I can and can't test. That's just the way it is. And theoretically, this isn't the way it will always be, and we will get to a better place, but it's an uphill battle. There are people working on it, but it's an uphill battle.
So I tell my medical students when they're rounding with me, learn what you need to know, but the insurance companies are going to dictate what you can do. So the one thing I do want to kind of emphasize that sometimes you can price shop your meds, okay? So just because like the UPMC insurance, sorry if you're out there, tells you have to go to like whatever, is it CVS or right? I can't even remember. But you know, you can look, Costco and Sam's Club, they have maybe different prices. There is that app, and I'm not in anybody's pocket. If you know, I could use extra money from these people, but I'm not. A GoodRx, there's an app, and you get a coupon, and you can go, and it's out of pocket, so it's out of pocket expense. So your out of pocket expense with those coupons sometimes are more than what your copay is with your insurance. I had somebody, and this is just word of mouth, I have not looked into this, Mark Cuban, who is a Pittsburgh native, the Mark Cuban pharmacy thing, I've heard that, I forget what, it was Requip XL, the patient came in and he said it was like $600 and he was paying like $50 or something like that. So there is a huge jump. So you may want to start looking into some of these other programs, not just settle for, you know, my insurance says I have to go there. There are sometimes even looking into doing the 90-day supply versus the 30-day. If it's still expensive, let us know. So the problem with some of the pharma is they do have patient assistance programs, but we are told time and time again that patients on Medicare are not candidates for it, which is, you know, the majority of the patients that we see. So sometimes it is, you know, going from, I'm not on anybody's pocket, remember, going from Stalevo to breaking it down to carbidopa, levodopa, and tacopone, because that could be cheaper, or maybe it's more expensive. So sometimes we can, as physicians, can change medicines around to kind of make it more conducive. We don't want to like gouge your pockets either. So sometimes we do change medicines just because of it, but we have some of these other tricks.
And I can add one thing too. Shout out to our Women's North support group who brought Blueberry Pharmacy to our attention. Kyle McCormick is the pharmacist there, and he can't do a whole lot to help with branded medications because that's really the pharmaceutical company's purview. But if you are taking something that has a generic alternative, talk to the foundation. We can give you more information about him. They will deliver to your home, and he is saving people hundreds of dollars a month. So,
And this is also why we have a team. I have a whole team over here because I can't take care of all this stuff. I can't figure all this stuff out. I would like to, sort of, but I can't. And so this is why I have a team. I'm sure that they have a team. Dr. Oblack setting up a team, I think, maybe.
Right now, a team of one.
Exactly. He's a team of one, but soon he'll have more of a team because it does take a lot of us to try to figure out Blueberry Pharmacy, prior authorizations, all the stuff that you guys and I don't really want to hear about, but we have to because this is part of how we get what we need.
And Dr. McCormick has counseled many people like Mark Cuban about how to get this going. He doesn't take insurance. But like Dr. Suski was saying, sometimes your out-of-pocket is a whole lot less without the insurance, which is hard to understand, but reality.
And about at least once a week, I'm going to say probably multiple times a week, but I'm going to say at least once a week, we are on the phone or calling companies saying why we think, or writing letters, why it's important that this patient gets this medicine. Sometimes we can push it and they approve it just by us saying that this was not our first drug of choice. And sometimes they'll say, well, you have to try X, Y, and Z first, and we can do that quickly and say that it didn't work as well. Sometimes, but we do this. This is a part of our other job, is not just seeing patients in person, but fighting with insurance companies about getting things approved for you guys.
And just to provide some empathy and sympathy for our panel, when they talk about these drug denials and peer reviews, it takes a tremendous amount of time for these folks. And I met with a movement disorder specialist out of Philly who said that he, in his 20 years of practicing in the PD community, he has never had a peer who was even a neurologist.
Right.
It's
And-
peer in quotation marks.
Yeah.
We just talked to an emergency room doctor last
Yeah.
I
He
have
sees a lot.
obstetricians, gynecologists.
Exactly.
Making
Radiologists.
decisions on your medicines.
OBGYN
Yeah.
is one of the folks
Yeah.
that this man dealt with, and he, because of postural instability, ordered a cervical MRI, and the response that he received from the OBGYN was, "That's ridiculous, men don't even have a cervix." So feel for these guys, it's bad.
And I've written letters that said this is, I want to have your name and your number attached to it, so if something happens bad to this patient, you're on the medical chart too, so you'll get sued as well for denying care.
Right.
And sometimes that pushes it a little bit faster. But it takes, I'm going to say a minimum of 30 minutes, and some of these phone calls, you're getting bounced from person to person. You have to have numbers, and all of a sudden they're like, oh, you're just calling back to, fight for it? Oh, since you just made the phone call, we approve it. So sometimes it's really fast, and sometimes we have to go through, like, jumping through hoops. But it's probably a minimum of 30 minutes. I think we all can agree on that one.
Yeah.
Well, and now we're going to pass mics around so people can ask questions from the floor. But one thing I hope you walk away with is that we are so blessed in Pittsburgh. Even though we don't have enough movement disorder specialists, we have really great movement disorder specialists. And the APPs who work with them are equally great. And so if you're having trouble getting in to see a movement disorder specialist, don't shy away from making an appointment with an APP. They are very good. They can help you. They're not restricted on time. You will less restricted on time. You have more than 20 minutes to get all your symptoms in. So please reach out to these folks, and we have others that we'd like to introduce you to down the road. Dr. Erval is up in Butler, and Priya Cardone couldn't be with us today, but many others who are joining this fight. So, any questions from the audience?
It's funny, I'm embarrassed to stand up a little because I promised Dr. Leichliter I wouldn't fall again, and I did, as you can see. There's a medication called alendronate that I take from my family doctor. But with alendronate, you have to take the medicine with 8 ounces of water, and you have to stay up. Can't go back to sleep. And then I can finally take my Parkinson's medicine, and then it's already time to go do something else. And I was explaining how difficult it is if you have Parkinson's to have to get up and get your care partner up again if you have to go to the restroom and stuff like that. So I said, the reason I want to take a monthly pill is that I'll take it on time. The alendronate, I miss a week here and there. And they're fighting me for it. And they said the doctor didn't give enough information. I said, well, can I give you some information? If it comes from the patient, sometimes they really listen. I said, you know what it's like to have Parkinson's. You can't get out of bed until your medicine gets in you. And if you have to take something before that, like alendronate or something, then you're up for the day because you can't go back to sleep. And she said, I understand what you're saying now. Now I understand. I'm going to, send a pill to you that you get the medication. So maybe they need to hear the patients speak and about what they need.
You mean we need to listen? Ridiculous. Well, and this goes back to the play, right? I mean, and I don't think anybody up here gets mad at our patients when they don't do specifically what we say to do, but it can be interpreted that way, right? And again, the vast majority of my patients aren't trying to let me down. They're trying to do what I ask them to do, and they're trying to take their medicines, and they're trying to exercise, and I'm well aware of that, but you're right. It's not easy. I say it. You come to my office, and I'm like, oh, how much exercise are you doing? All right, do a little more, because that's how it usually goes. But I also recognize how hard that is, and so the short answer is we need to listen better, and we're working on that.
Well, and it's a very good point, but for the branded meds, I would also like to share that you have experts in the field out here at our vendor tables, and they are a great resource for the branded meds and often have programs to help you with the cost of the branded meds, and they'll do everything they can to help you get those medications.
We have a question, right?
Maybe, no,
Is it working? Oh, okay. First, a comment. An easy way to cut your drug prices almost in half is just get the doctor to prescribe twice the dose and cut the pill in half. As long as it's not an ER. I mean, 250 milligrams cost $1. 500 milligrams cost $1.25. Easy. But what I wanted to ask is, with the Fox Foundation's work on diagnosing, not diagnosing, but the test for PD, is that available? Is there any way to know about PD other than, I think you could do it post-mortem?
That's the most definitive way.
Yeah.
You guys want to take that one?
I would say the gold standard is autopsy, and we're all too young, no matter how old we are, for autopsy. So, are you talking about the skin biopsy?
Or the spinal fluid?
Yeah, I think
Yeah.
he's talking about PPMI.
We haven't been able to get it. I don't know if you guys
I
have.
feel like most of us want better research, I guess, as well. For that, we have patients asking for that test, and we haven't, first of all, it's hard to get. Coverage is even harder, and then, what do you do with it afterwards is kind of the threefold. But we've had patients ask for it. Nobody in our practice is doing it at this time.
We've tried to get to CSF. It's not commercially available here, as far as I know. Even the skin has been problem with coverage. Even the skin has been trouble with getting it covered, getting it paid for. And realistically, I mean, I don't think anybody up here really needs that kind of a test or what that kind of a test tells us at the moment. Someday, maybe, but today, that's not really what we're going to base our diagnosis on. That's not really what we're going to base our plan or what we're going to do on. And so it's not as helpful, at least currently, as you think.
Do you feel the same way about DAT scans?
Yeah, I mean, DAT scan has a role, and I use a DAT scan when I'm trying to figure out what to do next if I need that kind of information. So a DAT scan's a dopamine transporter scan. It's not a specific test for Parkinson's disease. It lets you know you're in the ballpark. But similar thing. It doesn't usually tell me more than I think I already know. I'll use it sparingly if I'm really not sure what direction I'm going to go.
So DAT scans, I will say that insurance, okay, so Highmark
They
has
cover those.
claimed that it's experimental. Now UPMC years later is saying that it's experimental. It's been FDA approved since the beginning of 2000. So this is our fight now, is there are times when we think it's appropriate. If somebody's coming in with a funky tremor that we're trying to figure out for DBS or the deep brain stimulator surgery, is it one target versus the other target? Should we do? I've had some people on psychiatric medications that look very Parkinsonian. Those might be better because then we can, bring this to the psychiatrist saying this is not Parkinson's, this is drug-induced. There are times that we think it's important. It's just that we're having a hard time getting the insurances to cover it now. And like I said, it's UPMC and Highmark that are the two big players here. But some of the commercial ones, the Aetna, the Cignas, we can still do, and then the Medicare we can still do too. But if somebody's coming in and it clearly looks like PD to me, I don't think it's necessary. But there are times I like it. And the other thing, it's kind of subjective with the reader because the head could be tilted a little bit, and I'm like, this is clearly not right, but the radiologist doesn't have the patient in front of them, so sometimes the reads are not right either.
And another thing to consider is, a lot of times, I don't know about my colleagues, I'll have patients come to establish care with me. Their primary care physician has ordered a DAT scan, and then they come to me saying, I've been diagnosed with Parkinson's, I have a positive DAT scan, and actually, when you go back and review the information, they actually don't have a case that looks like Parkinson's, it looks like something else. And so like Dr. Leichliter was saying, things other than Parkinson's disease will give a positive scan. And so it can sometimes actually create more confusion from a patient's perspective, as well as among the physicians taking care of you, about kind of how to go about the case the best way. And so I agree with them. I use it sparingly because I think sometimes just defaulting to a test can sometimes create more problems than what it will solve.
And if you want to pay out of pocket, it's $20,000 roughly, so I don't recommend that.
Excuse me. I just wanted to share on the point about help with the cost of medicine. I'm going to mention these two companies, not companies, but foundations that are helping us. And maybe some of you have heard of them before or not, but if you haven't, check them out. One of them is, it's called the TAF, the Assistance Fund. Excuse me. If you can look them up, Google them on the computer. They will help you with your Parkinson's medication. They have no limit on how much they will pay. If you have insurance like we do and you go, you pay that, then there's the copay. They will cover the copay. So we get a lot of the medicine, it comes out to zero copay. There is another one called PAN, Patient Access Network. Maybe you guys have heard of this, maybe not. I just wanted to share because they really do help. Without those two programs, being on retired and being on Social Security, there would definitely be times when we would have to choose between getting her medication or paying our gas bill.
Which is
Just wanted to share.
I have two questions, but before I ask you my questions, on behalf of everybody in this room, I'd like to thank each of you for participating. Today is a Saturday. You are very busy people. Your education, your training, thank you so much.
Well, honestly, if you had it during the week, I probably would be in clinic and I wouldn't be able to participate. So this is the only day I can volunteer anyway.
Okay.
So we're good.
All right, my two questions are, number one, how much is age-related versus Parkinson's? And my husband is going to be 83, and so is it an age problem when something comes up, or is it the Parkinson's? And do you understand what I'm asking? Yes. Okay, that's the answer. Okay.
Yeah, I mean, that's hard. I mean, sometimes because people will say, is it my arthritis? Is it age? And sometimes we'll say, okay, well, if it's a certain symptom, does the dopamine medicines, if they help during that time, most likely it's a Parkinson's thing compared to if I take an Advil and it gets better. It could be an arthritis type of thing. Do I have to get up and move around? And I just need to lubricate my joints. Yeah, there are things that happen as we get older. Our hormones change, our joints change, everything changes. So sometimes that's our hard task to tease out. Is it a PD thing? But making lists is a good thing, so we can try to tease them out. But also timing the medicines when they kick in, when they go off. I mean, sometimes people say, I never feel that, but if you have it the first thing in the morning and you take nothing all night long and you take your medicine and then an hour, 2 hours later the medicine kicks in and then that symptom gets better, it's probably a PD thing. But, sometimes it's us teasing it out. But you're right.
All right. The other question, and it's an embarrassing one that people don't want to talk about, but the guy sang it in the song about number 2, bowel issues.
We talk about poop all day
Everybody
long.
just groaned.
All day long. Go ahead.
Everybody.
My husband has spontaneous bowel movements, and he can't always tell when it's going to happen. And is this a Parkinsonian type of a thing?
Everything can be a Parkinsonian type thing.
Yeah. The other
Everything.
thing, were you going to say anything else?
No, go ahead.
Okay. The one thing about, a lot of times we accumulate medicines. Could it be a medication side effect? The one thing that sounds weird is that you can have what they call overflow diarrhea. And it is that your bowels are so packed that the only way around it is around it, and it's liquid. So sometimes people will come in and they're saying they have diarrhea and they're taking Imodium because they're having accidents, and then that's just binding them up even more. So sometimes we have to do like an x-ray of the bowel, but it sounds funny that we want to make you poop when you're having diarrhea just because you're backed up that much. But, you know, sphincters, as we get older, also tend to get a little lax. So, you know, noises come out of us that we, just from standing up, or, you know, we laugh or giggle or sneeze and we pee. I mean, so things can be also age-related as well. They have, what are those pelvic floor exercises that sometimes help people too? I had somebody recently who had some bowel leakage, and he went through pelvic floor exercises.
Well, and again, everybody groaned because it's such a common problem. I mean, the GI system is always impacted, and so working on different ways to try to work on this or paying attention to it's important. So again, bringing it up is important. Yes, it's embarrassing, and people don't like to talk about things like this: bowel problems, bladder problems, sexual dysfunction, sleep problems, mood problems, but you have to, because again, we're not mind readers, we're not that good. And so bringing it up at your appointment, there's usually something or someone I can get you to work on it, or we can get you to work on it, so bring it up.
I also have another point, is that it might not be Parkinson's, and it might be good to review with a primary care doctor or a gastroenterologist, just to look at other ideas and make sure there's not a structural change before we blame it on Parkinson's too.
Yeah, there are neurogastroenterologists. We all subspecialize in everything, and so do the GI people. There are some neurogastroenterologists as well. Yes. Yes, there's some. There's one, at least one at the VA, and there's a couple of them. I think that they have a whole motility clinic down at Mercy.
Is it okay if I say their names?
Please do, because we don't have one.
Yeah.
I was going to say, I don't know.
Dr. Kingsley and Dr. Leventhal. Is it Leventhal?
But there are some people that they have trained that are equally as good as well. That might be easier to get into. But they have a GI motility clinic. That's what you ask for. I think Kingsley's at the VA.
Okay.
Yeah.
One more question.
Hello. I have two questions. First off, is fatigue part of the problem onset after you are diagnosed with Parkinson's disease? And besides exercise, does housework and yard work as a combination?
What was the first
I was
question?
going to say, I'm going to answer the second question, and then you have to repeat the first part because I missed that one.
Either.
So the short answer is housework, which is what everybody tells me, right? I say, oh, do you exercise? Oh, I'm active. I'm up and down the stairs. I'm doing laundry. I'm doing the dishes. And I say, that's great. Doesn't count as exercise. It's good. It's better than nothing. Being active is better than being inactive, but I want more. I want it to be more. It's got to be a little bit of work. It's got to be more than just typical day-to-day activity. If you can get your heart rate up, great. If you can break a sweat, great. That's what I'm looking for exercise. Again, that's better than doing nothing. The last thing I want you doing is sitting around watching TV. Don't do that. But I would say that's activity, not exercise. I want you to do more.
I also get the yoga. It does yoga and Tai Chi.
Stretching.
Yeah, that's stretching. We want your heart rate up more.
Just do more.
Yeah, that will help. That will help with balance and falls, but as far as exercise is concerned, it doesn't count.
Now, what was the first part?
Fatigue.
Fatigue.
Is
Number
it-
one complaint I get in my office.
Okay.
It's a hard one because it doesn't seem to respond to the medicines as well as I would like, and I have yet to find a good solution outside of. See, everybody knows the answer. It's exercise. That's the one thing that tends to give people energy or help them get a little bit of a boost. But it's the number one, I don't know about them, but it's definitely the number one complaint that I get in my office: fatigue, tiredness, lack of motivation, apathy. And it's a really hard problem to fix. So you got to be active, keep getting up, keep moving. This is what I tell all of my patients. And I try different things, but it's a really hard problem to fix. I haven't been able to solve it very well with medicines. It really comes down to being active.
Sometimes it is a medicine side effect too. Excessive daytime sleepiness with the dopamine agonists, or it can be a sleep issue. You're not sleeping overnight, and so you're fatigued and tired during the day. I mean, so sometimes fatigue and being tired, they're technically not the same thing, but people can feel, they can express it as the same thing. It can also be iron deficiency. It can be, it could be a medical problem like thyroid issues. So it should be also brought up to the PCP, but we need to know And did you feel more fatigued right before your medications are due? Is it a wearing off phenomenon? Is it in the peak of the doses where it's the medicine's causing it? So sometimes timing of symptoms is very important for us as well.
And unfortunately, they've actually done studies of stimulant medications for Parkinson's patients experiencing fatigue that all of these other causes have been ruled out. And for some reason, the stimulant medications just don't have a good effect for addressing Parkinson's fatigue. And so it is just one of those issues that, again, we keep telling our patients, try and stay active, try and exercise. That can help keep you awake and moving during the day and make you sleep better at night, which kind of is, addressing both problems, but it is a very difficult thing to address.
That hasn't stopped me from trying them.
Yep.
But you're right, not all that great.
Yep.
And
Well, I
drink
think
more
as
water.
you can see here
Oh, yeah,
today.
drink more water, because it could be a blood pressure problem too.
Yep.
And it could be the medicines doing it. Get one of those hats that are the baseball hats with the tube, right to your mouth. Or
Water,
get one
not
of those
beer.
Camelbacks.
Beer bongs for PD. I think what we've demonstrated here today is how much expertise we have, but they can only be as good as the information that you share with them. And I think that's what was depicted in the play. And, this community tends to be gritted out, say everything's great, even though it's not true. So if you're not willing to share, bring your care partner who will tell the truth. So we're going to take a break, but Joan, our artist, would like us to auction off the painting now. And I'm told that Mr. John Dean is going to be our auctioneer. So I will be like the studio wrestling lady and hold it up. But please come back after the break, because the new Dr. Josefa Domingos, who is walking out of the room right now, is going to be doing a wonderful program on exercise and helping to roll out our new boxing program.